On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
I'm Peter Block here at ACC 2013. With me is Jessica Mega from the Brigham and Women's Hospital, the Timmy Group in Boston. And we've been talking about double antiplatelet therapy, that thing that won't go away. Jessica, Medtronic has now put together a lot of data about the Endeavor stent. And what are we learning about double antiplatelet therapy? When can you stop it? When can you not stop it? Do we have to do it for a year? Do we have to do it for 50 years? I mean, what's going on here? Sooner or later, we have to get to the end of this, don't we?
Absolutely. So we know that patients with acute coronary syndromes, those undergoing stenting, they require dual antiplatelet therapy, or at least that's what the guidelines have been telling us. Now, I do think it's important for us to remember patients with ACS are different than those just undergoing PCI. But in this group of patients, as you mentioned, that were followed, about 40% of them were ACS patients, meaning 60% were not. About 30% were diabetics. And it's very interesting. What they saw is that stent thrombosis rates, as we've known, were very high or relatively high in that first month.
Right.
So about 75% of the stent thrombosis events that they ended up seeing over a year really were in that early time period.
So what happens, the early time being 30 days or ish kind of stuff. And we all know, I mean, that bad stuff always happens and always probably will because of probably the fact we don't put the stents in perfectly. But then after that, with ongoing DAPT, what happens?
So what they ended up doing is breaking down the cohort, looking at those who stopped after 30 days, so after 1 month, and then those who stopped after 3 months. And if you look at patients who stop within the first 3 months, if they stopped their dual antiplatelet therapy, those patients did have higher event rates, higher stent thrombosis rates than those who didn't stop. But interestingly, those who stopped after 3 months didn't have a hazard. And so it leads us to question, in these types of patients, could we be stopping dual antiplatelet therapy earlier? But I will caution and say it was up to the treating physician's discretion. So maybe there's something different about the patient that you keep on dual antiplatelet therapy for a longer period of time.
I will tell you, Jessica, if I see a patient who's having an acute coronary syndrome and I think that they need their antiplatelet for some other pleiotropic effect, just because it's good for you, quote unquote, whatever that means, I would tend to take a patient that was more unstable and say, stay on it, wouldn't you?
Absolutely, and that's why, since this wasn't a randomized look at this question, we need to take it within that context. The other thing we always talk about is treating the stent, so that's one issue, stent thrombosis, and to your point, what about the vascular path, the patient's entire bed of arteries? And I think we do have to consider both those issues when we think about dual antiplatelet therapy.
So, for a stable patient, I would say, you know, after 3 months, maybe discontinue it if for some reason they can't afford it or whatever. There's one issue, though, that troubles me, and that's the patient who's going to have an operation. Because the milieu in which they then set themselves is very different because of all the inflammatory stuff that happens postoperatively and intraoperatively. What do you think? Do you think they should be then tied over with a 2B3A IV for a week, or how do we do that, and when do you say it's okay?
Well, I think the first thing to do is to make sure the patient really needs to be off their dual antiplatelet therapy. There are many procedures and many surgeons that are willing to operate with these medicines, but you're right, there are certain procedures where it is just not tenable to have both agents. In that case, we certainly don't have data to suggest that bridging with a 2B3A would be a reasonable option. It is for certain patients, certainly high-risk patients. Let's say someone has a proximal LAD stent. There's also cangrelor that may or may not be available, and I think that could change the circumstance as well. So more therapies potentially available. It's a patient-by-patient decision. What's their cardiovascular risk? What kind of stents do they have in place? And it certainly makes our job interesting.
So let me ask you one thing. If you had a stent in place, would you take your 2B3A or your antiplatelet agent for a year?
If I was not having problems, I would.
I thought so. Thanks, come on back. We'll have lots more interesting information from ACC 13.